My name is Andrew Cox. I'm a British Army cardiology trainee, and I've been doing research with Professor Sharma into screening in the British Army. And this is just, again, a fairly unscientific discussion about our experience. So when I came to the group to do this research, I first wanted to quantify what the actual problem is. It's very hard to hit a target if you don't know exactly what you're shooting at. So our first thing was to look at deaths in the armed forces. They certainly occur. This is a Daily Mail online report of a young man, a father, who's joining the army and died during his entry medical. There are other reports similar to this. We looked, fortunately, we collect deaths prospectively and discharges, so we were able to look at the rate of cardiovascular disease in the armed forces. We found that there was about 7.5 deaths per 100,000 overall. Most of those were due to coronary artery disease later in life, but in the under 35s, we had a death rate of 3.8 per 100,000, which compares in a similar sort of way to Professor Corrado's data from Italy, which was 3.6 per 100,000. And about a third of all our deaths were due to inherited causes. So the mission, really, over time, is to try and reduce the number of these deaths. We've said 50% by 2023, so 10 years. We may overshoot with a bit of luck, but we'll see. And to do this, really, we have to identify the deaths to start with. The people who are going to die. And that comes down to screening in the main part. And so what we've done is we've reviewed and brought in a new screening system for cardiovascular disease. And obviously, it's also lifestyle measures and medical interventions to prevent death, including defibrillators on site and so on. So the rest of this presentation is just to talk about the screening itself. And the aim of the screening was really to produce a system which detected more disease than what we had in place under the old screening system. And the old screening system was obviously not picking up enough because we're still having lots of deaths. Okay, so we also wanted to have as few false positives as we could. And a false positive, as far as we're concerned, is someone who turns up for their medical and gets sent away for further investigations. Doesn't get passed in the day, and it produces lots of delays to the recruiting process and costs. So overall, we wanted a program which was either cost neutral or reduce the cost overall. It had to be evidence-based, and Colonel Booz, who's also here, unfortunately, and I were able to develop this system in a sort of evidence-based manner. We drew on the CRI experience, and it's loosely based on the CRI screening system and the European Society guidelines. And then we implemented it from the beginning of last year. It actually came in April last year. But to do that, there was a lot of training, and since then we've been optimizing what we're doing and validating the system. So the old model that we had was a history, much in the model of the American Heart Association system, and a physical examination. The history was done, first of all, by a GP prior to the candidate who wants to join the army turning up for selection. And it wasn't just a cardiac history, it was a general medical history. The most common cause of discharge in armed forces is musculoskeletal. The most common cause for failure to join the army is musculoskeletal or psychiatric problems. So, it's not just cardiac issues that we're looking at. The examination is the same sort of examination. It's a pulse check, a blood pressure, and an auscultation. And then, if in the old system you had a murmur, you were referred for an ECG and echo paid for by the Army with a private company. And we had a very good service with them, but it did mean that the people who went were the only ones who got the ECG. So you had to have a murmur to get an ECG. What we did was we changed the system. We brought the tests in-house so that everyone now gets an ECG and an echo if you have an indication. So that could be from physical examination, or it could be as a result of a predefined ECG abnormality. And the task itself was pretty big, setting all this up. We screen about 20,000 people a year for the Army. It's a 2-day process. Day one includes a medical and some intelligence tests and so on. Day 2's team building, physical examinations and so on. It's a big business. We've got 5 centres, and it's, there's several steps to it. The impact of failing somebody in the medical has an impact further on down the line, and so we had to minimise that failure rate. We have about 100 doctors who are doing the medicals. Now, most of these are generalists. They're primarily GPs, but we have some retired surgeons and radiologists and a few physicians. We don't have any cardiologists. We don't have any specialist cardiologists doing it. And actually, we probably wouldn't want to because, as I said, most of our issues are to do with musculoskeletal disease, psychiatric illness, asthma, other medical complaints other than heart disease. We had to train up the ECG technicians, so we had people who worked with us already, and we went around and spent a bit of time on a sort of roadshow doing training, and we had to sort out an echo service. And we have a private company doing this called Ecotech, and I'm pleased to say a whole load of them are here today, are mostly sat over there, and they're excellent. And so we've got about a dozen of those. There's one technician at each location each day. And then what we have is a system where if the GP does the examination and sends the patient, the candidate for an echo and isn't sure what to do with it, then we have a backup service. So they can then get a cardiology opinion that day on whether they can pass or fail a candidate. The doctors who are looking at the ECGs and echoes have a protocol which is sort of drawn from the European guidelines really, but adapted to our system. So, for example, we thought the long QT interval was too short and went towards the American system. This was based on data we've got from military ECGs done in aircrew. And when the doctor who's looking at this looks at the ECG, they'll see some abnormalities like these T-wave inversions, and they'll be able to cross-reference it to the protocol, which shows that it's abnormal and it needs a referral. We do an echo on the day so we can get a better idea of what's going on. So if we have an echo that's diagnostic for hypertrophic cardiomyopathy, for example, we can say that to the GP, refer directly to someone because this is a diagnosis. But that does have some issues with counselling and so on. So the echo acquisition is excellent. We've got this great system. We use vivid eye machines, and they have, the technicians produce a report on the day, which is to the BSE standard. But the best thing about the system, I think, is that the images can be saved onto the internet, onto an encrypted software package, and it means that we can have an immediate cardiology opinion if we need to. So since we set it up, we've screened about 30,000 people, and we really have to now validate the system, and that's where I'm primarily coming in. My work is looking at defining normal values. We've got lots of data from Italy, from the US, but they're a completely different population. Most of them are done on athletes. Most of the people who turn up to join the army are not athletes. They're people, like many of the people in this room, who just fancy a different lifestyle. And a lot of them haven't done the exercise in years. We're recruiting based on potential, not on whether they're already trained. We're also collecting data on the sensitivity and specificity, not just compared to one particular guideline, but looking at lots of different parameters to try and work out the best system for us. And we're looking at the cost effectiveness and overall, in long term, the mortality impact. So my main project is looking at the sensitivity and specificity. All my research volunteers have got no medical history, so they've got nothing positive in their cardiac history. So I can't tell you about what we're not letting in. But they all have a physical examination, an ECG and an echo, and that's our sort of gold standard. We do extra tests on people who need them. So if you have T-wave inversions and you get referred, we'll do an exercise test, a cardiac MRI, 24-hour tape. So far, I've got just over 800 that we've analysed. Most of them are male, 88.5%. Most of them are white, but we've got 10% who are black and 3.5% who are of South Asian origin, mostly Nepali. The families from Gurkha background normally. We have quite a few group 2 ECG abnormalities using the ESC criteria. It's about 12%. And these are the sort of the positives, really. So we've had 6 who I haven't got any results on yet because they're still undergoing their investigations. One of them had by Germany, and the remainder had T-wave inversions. They all had normal echoes. We've had 10 false positives, that's just over 1%. 2 of them had borderline long QT syndromes, and the remainder had T-wave inversions. And they were all cleared following specialist cardiology referrals. We've also had 17 true positives, of whom 13 we failed. Now, we have a different reason for failure to, say, the European guidelines, because we're recruiting people for a 22-year career, not just another year of exercise. So we've got a slightly different perspective on it. However, these are what we've picked up. So the yellow on the left-hand side are people who had a murmur and would have been picked up in the old system. The people in red have got things we picked up on the ECG, and the 2 in white in the bottom right are people who had neither a murmur nor an ECG abnormality. They're the people who got through. The VSD at the bottom right was tiny, and we passed them, and we had 1 bicuspid aortic valve. The things that we picked up with the ECG under the new system were all potentially fatal conditions. One's a long QT. We had 3 accessory pathways and 1 hypertrophic cardiomyopathy. The ARVC, I've only just heard back on in the last couple of weeks, and it's probable they've had a cardiac MRI, which is fairly conclusive, though, so they're not going to be joining the army. So just to summarize then, we've got a new ECG system for screening. We think it's pretty effective. We haven't fully quantified that yet, though, but work in progress, as Ahmed said. We're picking up more disease, though, under this new system, and we are deferring far fewer candidates than previously. And as a result, we think the system is going to be undoubtedly less expensive than before. So we've seen this graph a lot. The red line at the top is where the Army has been for the last 17 years. And hopefully, with a bit of time, we will drop our mortality rate down to the 2001 findings from Italy. So there's a lot of thank yous for a project like this, both academic, my ECHO team, Army and Capita, who have the contract for the screening. So any questions?